This exercise case study is of a 53-year-old office worker who has been referred for an evaluation of shortness of breath. She has a 44-pack-year history of smoking, continued to smoke up into the time of her test. She claims she has a morning cough that produces thick white sputum, 50 to 100 mL per day. Her chest radiograph shows increased vascular markings and mild hyperinflation. She was not taking any medications at the time of this test. She has no family history of lung disease or cancer, and she has had no environmental exposure. Looking at her spirometry, it's pretty clear that we find an obstructive condition. FVC is 97% of predicted, FEV1 59%, FEV1 to FVC ratio is 46%, FEF 25 to 75 is 27% of predicted, with an increase to 42 after a bronchodilator, so that's a significant change. So overall, looking at her spirometry, it shows an obstructive process with a well-preserved forced vital capacity. There is only 5% improvement in the FEV1 after her bronchodilator. However, we did see with that FEF 25 to 75 that it did go up to 42%. Looking at her lung volumes, we see her vital capacity 98% predicted. FRC is 123, so we know there's some hyperflation, which was correlated with her chest x-ray. Our residual volume and total lung capacity are both elevated with a ratio of 44. So her lung volumes by body plethysmography show an increased FRC and RV consistent with air trapping. TLC is close to normal, so there is a little hyperinflation, as we mentioned with the chest x-ray as well. Next, let's take a look at her DLCO, which we see it is decreased at 44% of predicted, and then even after adjusting for the hemoglobin and carboxyhemoglobin, it's still decreased. Blood gases then on room air show that she does have some hypoxemia, and then she does have that elevated carboxyhemoglobin, which correlates with her continued smoking, which she did tell us about. So taking a look at our exercise test, we do see that it took place in two different parts. She started off on room air, okay, and then we had to add oxygen. So looking at rest, okay, on room air, she was breathing 16 breaths per minute. Her minute ventilation was 10.2, alveolar ventilation was 6, tidal volume 600 milliliters-ish, dead space 262 milliliters, with a dead space to tidal volume ratio of about 41%. That's a little high. As she continued to exercise on air, we do see that her respiratory rate increased as it should, minute ventilation increased as it should, alveolar ventilation increased, tidal volume increased, her dead space increased, and we see that her ratio actually decreased. Once she was placed on oxygen, notice her minute ventilation is elevated, and even with exercise, it does increase as it should, expectedly. Her alveolar ventilation is elevated, and it increases with exercise. Tidal volume is elevated, and then notice it doesn't increase quite as much with exercise now that she has the oxygen as compared to when she was just on room air. Dead space is very similar, and then we see our dead space ratio does not change near as much and is actually lower when she is receiving oxygen as compared to when she was just on room air. So what does this tell us? We know that ventilation was slightly elevated both at rest and it increased normally, but when given oxygen, the ventilation was slightly lower both at rest and at similar workouts. The dead space ratio was mildly elevated, and then it decreased with exercise both on air and oxygen, and we saw the subject's minute ventilation was about 51% of her MVV after her bronchodilator. So let's keep going here. Okay, our data here is in the same order, so these three rows are on air. We start with rest and then with exercise, and these last two are with oxygen rest, and with exercise. So we see the patient achieved a peak VO2 of 9.986 liters per minute while on oxygen. This is 53% of her age-related predicted value. This is consistent with moderately severe exercise impairment, and the ventilatory equivalent for O2 is within normal limits, and her O2 pulse increase normally, although it did not reach maximum values. Looking at her blood gas, we see that she has hypoxemia both at rest and with exercise. Her PaO2 is 61 mmHg and also has that elevated carboxyhemoglobin. Her PaO2 decreased to 47 mmHg while on air with only a slight exertion. On 28% oxygen, the PaO2 improved to 84 at rest, but then decreased as her workload increased. Her PaCO2 increased slightly during oxygen breathing, so just a little bit there, possibly because of respiratory depression. Carboxyhemoglobin was elevated, as we know, probably from her continued cigarette smoking. And then her pulse oximetry during exercise shows readings higher than the actual saturation that we got from the blood gas, presumably because of the elevated carboxyhemoglobin. So remember, anytime your carboxyhemoglobin's up, your SpO2 is going to read higher than your SaO2. Looking on at her hemodynamics and heart rate, the heart rate and blood pressure responses were appropriate for the workloads achieved while breathing both on room air and on oxygen. The low maximal heart rate suggests an exercise limitation other than cardiovascular pathology or deconditioning. There was nothing special on the EKG, so we don't have it to look at. So when we take a look at everything overall, we see a moderately severe exercise impairment, primarily caused by desaturation during exercise. She also has some ventilatory limitation, which is probably present, and then her desaturation is aggravated by her elevated carboxyhemoglobin. So here we have an individual with obstructive lung disease. When put to an exercise test, she did not reach the maximal effort as we would expect by her heart rate or her oxygen consumption. We did notice that her oxygen levels did decrease rather rapidly. We then put her on some oxygen and continued the exercise test, and with the addition of oxygen, we actually saw her ventilation or her CO2 increase as well as her oxygen decreasing. So what's the cause of that? It's hard to say. Obviously with her productive cough, we assume there's probably some chronic bronchitis going on, so she might be having a little bit of shunting going on because there might be a little bit of a VQ mismatch going on there, so maybe some shunting or some venous admixture. So while we did have her breathing oxygen, we would have expected her to desaturate to a much lower level in order to consider that to be the cause of her exercise limitation. But that didn't happen. So hypoxemia was not the cause of her exercise limitation. She also did not increase her ventilation to a maximum level. So what does this tell us? It suggests that deconditioning was responsible for the low maximal workload achieved. However, if it was deconditioning, then we would have expected her heart rate and blood pressure to increase a little bit more, because that's usually what we see when there's significant deconditioning going on. So another thing we should consider is maybe she just didn't give us a lot of effort. Maybe she had some bronchospasm during the test. We didn't do a pre and post bronchodilator there. Or maybe she just had an increased sensation of work of breathing, and so that was her limitation there. So the treatment that was chosen for this patient, she was put on a formal effort to stop smoking and hopefully eventually quit. She was also referred for pulmonary rehab, which included bronchial hygiene, breathing retraining, and exercise with supplemental oxygen. She began using nasal oxygen at 1 to 2 liters per minute for exercise, and then a follow-up evaluation was recommended in 3 to 6 months after smoking cessation.